Hello, everybody, and welcome to Conversations in Lung Cancer Research, a TOGA podcast where we discuss the latest breakthroughs in lung cancer research and treatment for Australia and New Zealand. My name's Associate Professor Mel Moore. I'm a medical oncologist at St Vincent's in Melbourne, and I'm on the TOGA board and education chair, and that gives me this great opportunity to take part in these podcasts. Today we're doing something a little bit different from our normal focus on research and data. We'll be interviewing someone from the lung cancer community and learn more about their journey, for want of a better word, in medical oncology and lung cancer research. Before I start, the Thoracic Oncology Group of Australasia would like to acknowledge the traditional custodians of the land on which we live and work. We pay our respect to their elders past, present and emerging. We also extend that respect to all Indigenous people. So in today's episode, we'll be chatting to Professor Michael Boyer to find out more about his career from being a medical oncologist to his current role as CEO of the Chris O'Brien Lifehouse. This is a particular delight for me, as Michael was my very first head of department when I was a basic trainee doing oncology terms over 20 years ago now. So it's a real thrill to be interviewing him in this forum. Michael's been a medical oncologist for more than 30 years and specialises in the treatment of thoracic and head and neck cancers. In 2010, he was made a member of the Order of Australia for his work as an educator, a clinical trials researcher, and for his involvement in the development of integrated cancer care facilities for people suffering with cancer. He was appointed the Chief Clinical Officer at Chris O'Brien Lifehouse in 2011, and more recently was appointed the Chief Executive Officer in 2023. I'd like to welcome him to TOGA's Conversations in Lung Cancer Research podcast. Welcome, Michael.
Thanks, Mel. It's an absolute pleasure to be being interviewed, especially by you.
Thank you, Michael.
You said that it's an amazing thing for you. Well, it's even more amazing for me to see people succeed over many, many years, and you've certainly done that.
Thanks, Michael. That's very lovely. Michael, without making this sound too much like an episode of This Is Your Life, I guess we just start by you sharing your trajectory through medical oncology and what drew you to medical oncology and what your pathway has looked like from that time.
Sure. You go back 30 odd years to when I started my training. And at that time, medical oncology, relatively speaking, was underdeveloped. We had a number of diseases that we treated, but lung cancer was not high on the list of things that people thought of when you thought of medical oncology. Neither, for that matter, was colorectal cancer, sarcomas, and a whole lot of other things. It really was a very different time. And for me, at the beginning, the choice to do, or the decision to specialize in medical oncology, was one driven by what I saw as enormous potential. For me, this was an area that just had this great opportunity to do things better than they were being done at that time. Now, as events have turned out, I think I was lucky and made a decision to go into a field that just exploded. I didn't know that at the time, obviously, although I had hoped that would be the case. And for me, starting at that time, it was just an amazing thing to see the basic science that was being done then get translated into the earliest sort of treatments, and then that developed further into the sort of field that we see today. So I started off with my training here in Sydney at Royal Prince Alfred Hospital. I had some fantastic mentors, people like Derek Raghavan, Martin Tattersall, Alan Coates, and John Symes, I should say, who really guided me and helped me in my initial training and helped me in a decision that was an important one for me, which was to go and do a PhD in Canada at the Ontario Cancer Institute and Princess Margaret Hospital. And that's when I was really first exposed to some of the fabulous basic science, which, as I say, forms the basis for much of what we do today. From there, I also developed, or in that institution, I also developed my interest in lung cancer. Unlike the situation in Australia at that time, and we're now talking the late 1980s, the institutions in Toronto had had a long-standing interest in the treatment of lung cancer, initially with the use of neoadjuvant treatment with neoadjuvant chemotherapy, but then also in the treatment of advanced disease. And that's what sparked my interest in lung cancer, and it's been an interest of mine ever since. After that, I came back to Australia and began work. And, from there on, it's just been a fairly steady progression.
And Michael, just going back right to the start where you first had the inkling that you wanted to do medical oncology, were you a medical student? Was it as a result of doing a term in medical oncology as a junior medical officer?
It was the latter. It was, and actually very specifically, it was doing a term as a junior medical officer in medical oncology and having fantastic role models. And some of the names that I mentioned earlier were those role models. And I think it's really interesting to what extent a good role model can shape someone's career. Certainly been my experience, and I've seen it with a number of my colleagues as well, not just in medical oncology, in other fields also, where someone really ignites that spark, so to speak.
Yeah, I think that's interesting to hear you say that, because that was certainly my experience. I had no inkling of doing oncology until doing a term as a basic trainee, and obviously liked the work and the patients, but it was really the inspiration of the department and the friendliness of the department. And I look back and think, well, was that a good reason for choosing to do oncology? But I think it's turned out okay. So interesting to hear that was a similar experience for you as well.
And I think for all of us, we're very lucky because myself and you and many other people around us have chosen to specialize in medical oncology at a time when there's been just enormous development in medical oncology. Everything from better forms of chemotherapy through to targeted therapy, through to immune modulation and immuno-oncology. It's really been a very, very exciting time. So to some extent, anybody that chose to do medical oncology in the last 20 to 30 years has been there at the time when, as a specialty, things developed very rapidly.
Yeah, you're right. It's a very lucky time to be in this field. Michael, now when I first met you, you were already head of department at Royal Prince Alfred at that time, which then subsequently became Lifehouse. I would imagine that for a lot of people, they don't go into medicine aspiring to head of department or those sort of leadership roles. And I suspect that some people probably fall into it because they're the last person standing or might have their arm twisted. It's certainly not done for financial gain. It's, I'm sure, a lot of more work for not really much more financial gain. What was it that drew you to that sort of leadership position? Because you've stayed in leadership positions your entire career.
Look, it's really interesting as I look back on it. I'm not even sure that I remember what first drew me into it, but having gotten involved, it became really apparent to me that you can do a lot of good for a lot of people, both patients and your colleagues, by ensuring that systems run well. And that's true whether you're talking about an individual department, a division, or a whole hospital. And so once you, I suppose, dip your toe in the water and understand that and understand the benefits of being able to run things and being able to shape things, it becomes almost addictive, I think. So it's been very easy for me to stay in those sort of roles because I don't think I've done everything I have to do yet. I don't think I've contributed as much as I can contribute, and it just goes on and on and on. You find that you learn a huge amount about how to run things. You learn a huge amount about people, and you learn a huge amount about, as I say, how systems and system changes can actually do good. You also see the reverse, by the way. That is, you see badly run systems or badly run institutions and the harm that does to the people that have to work there and the harm that it does to the patients who have to put up with a system that doesn't work well.
And have you ever felt daunted by any of the leadership roles that you've taken on, or that you always felt quite confident and calm in those roles?
No, I've felt daunted by every single one of them.
Is that right?
And I think that to some extent, as an individual, I like challenges. And I think if you don't feel daunted, if you feel overconfident, then I think there's a problem. Being daunted, by the way, is not the same as saying you're scared. Being daunted just recognizes that there's lots of things to learn, there's lots of things you can do better, and, effectively sets you on a direction to improve and to do those things.
So you mentioned some of the mentors you had as inspiration for becoming a medical oncologist, but did you have that same sort of level of, I guess, go-to people in taking on leadership roles, or you felt that you were really, I guess, on your own in that regard?
No, I've certainly never felt on my own. I've been very fortunate in every one of the leadership roles that I've had to have people around me who I can go to for advice. Sometimes it's unsolicited advice. Sometimes it's very much solicited advice. People who support me, and in my current role, I have a fabulous board of directors who are very, very supportive, who have great skills. And I think that the thing about this is that none of us know it all. You really do learn a huge amount from the people around you, and it makes you do your job better. And that's what I've tried to do. And that actually has been a characteristic in all the leadership roles I've had. And sometimes it comes out of left field. It's not always another hospital administrative person. Sometimes, they're people from allied fields. I mean, I've learned a huge amount from lawyers, from people in business, where the parallels aren't always immediately obvious, but as you start talking about things, it becomes clear how much you can actually gain from taking on some of their knowledge.
So, Michael, in addition to your leadership roles, you've also had a long involvement in clinical research, so both cooperative group, pharma-sponsored trials. I guess for some more junior listeners, that the path into that sort of position may not be clear if you're a basic trainee or advanced trainee. How did that come about for you that you got heavily involved in clinical research within medical oncology?
I think it really comes about by being, firstly, enthusiastic, being prepared to do the work. Like everything that you achieve, it doesn't happen without working on it, without spending time on it, and without developing relationships. And I guess of those three things, I mean, the thing for me that makes the biggest difference is developing relationships. So talking to people who are already involved in this, understanding what they're doing, really being interested in what they're doing. If you do those things, the opportunities come soon enough. And once you have your first opportunity, you build on it. I don't think that I'm sort of saying anything that anyone would find surprising. It's how you succeed in most things. Find the first opportunity and then work on it. And it's never easy to start with because you always think, number one, that you're not good enough. Number two, that it'll never happen. It'll never work out the way you want it to work out. But it does. And I've seen it happen over and over again, not with myself, but with people around me, yourself included, as well as many other of my colleagues and many of the other people that have trained with us.
I guess just in terms of, sponsored trials, you're obviously presenting big trials internationally that you've been involved with. Has that come from pharma approaching you, from just your experience and sort of working your way up the ladder, in terms of clinical trial involvement?
Yeah, I think it changes over time. How it was at the beginning was just working my way up. Later in my career, I got approached more than having to do the approaching myself. But that's what happens as you get known and as you talk to people. But, again, I can't overemphasize how important those relationships are, that you get to know everyone. And then once you know people, they will do the inviting. And that's what happens. I mean, I was incredibly lucky to get involved fairly early in my career with IASLC. And as a result of that, met a whole lot of people globally who are very, very heavily involved in lung cancer research, lung cancer clinical trials. And once you get to know those people and work with them, that opens the door to being invited to participate in clinical trials. And from there on, the outcomes of those trials have to be presented. And the more involved you are, the more you've contributed, the more likely you are to be, number one, an author, and number two, the person that's presenting the trial.
And just in terms of that workload and what you do to rise up the ranks and get known, I mean, I've heard various people speak on career advice and some people say, well, just grab every opportunity you've got, don't say no to anything. And then I guess you reach a stage in your career where you feel like you have to start saying no to things and being a bit more selective. I'd imagine you're probably at the being a bit more selective stage, Michael, but can you think of a sort of a point where that transition happened, if at all?
Yeah, look, the transition does happen because, early on in your career, you have to basically, I think, say yes to more or less everything. But I think it becomes important fairly early on to decide what your focus is, because if you don't focus, you end up, being torn in multiple directions, and you just don't have time to do anything well. So, and there's no specific moment in my career where I remember saying, well, I've now made the decision that instead of saying yes, I'm going to start saying no. But it does just happen, and it happens as a consequence of how much time you've got to do things and what's important. For me, to some extent, the more heavily I got involved in administration and in leadership, the more I realized that I just couldn't keep doing everything because there are just not enough hours in the day.
And Michael, just in terms of, and you're obviously a foundation or an inaugural member of the TOGA board and instrumental in helping setting up TOGA, and you've mentioned you've been involved in IASLC. What changes have you seen over the journey in terms of cooperative group and investigator-led research, and what are some of the challenges that are ahead for us in terms of doing that sort of research?
Look, it's a really good question, and I think that throughout probably the last 15, 20 years, there's always been a tension between what the pharmaceutical industry is doing, and quite rightly, the pharmaceutical industry is focused on developing their own products. It helps patients, obviously, but the focus of the pharmaceutical industry has to be the development of their products and ultimately bringing them to market. So there's a tension between that and answering questions that are of no interest to the pharmaceutical industry, but may be of great interest to clinicians and patients. And, as a researcher, it's tempting to be all in one camp or all in the other camp. And I think that that's a mistake in either direction. It's a mistake because I believe you really do need both those different sorts of research. Now, that's been the case for a long time. The difficulty for cooperative groups has always, in Australia in particular, has always been identifying and obtaining the funding to be able to carry out the very many great ideas that bubble up. It's a reality that there is never adequate funding for everything that we want to do. On the flip side, the difficulty with the pharmaceutical industry is that you might have something that's happening that's of academic interest to you that happens to coincide with what the pharmaceutical industry wants to do, but you might not. And so you can't really rely on that either. So I don't have any clever answers other than to say that well-organised cooperative groups represent the best opportunity to obtain the support, obtain the backing. And the backing doesn't always have to come from grants. It can actually come from industry, and it can come from a whole lot of sources. But having groups such as TOGA, which can actually bring together the expertise and present it in a way where the group is credible, it has an identity, and it has a presence, really offers the best opportunity to get that funding and that support.
And I guess just in terms of looking at the future of who's doing that research, what do you think are the best ways to encourage people into a research career and get that experience and that, I guess, that passion for research in an environment where it can be hard and disheartening to get funding to do what you want to do?
Well, I would add to the hard and disheartening bit where you don't really have the time, because the reality for many of us is that if you're a busy clinician with a busy practice, it takes time to do research. It takes time to come up with the ideas, time to promote them, time to get it through the system. And then once you're doing the research, it takes time to put patients on trials and do all the things that go around it. So there are plenty of barriers. I think that the payoff, if you like, the thing that drives people to do it is that the interest and the benefits of being involved in pushing a field forward, I think, are so big that that's the reward for doing this, for all the hard work that needs to go into it. It's also, and when I referred earlier to the sort of relationships you build, it's also a really good way, if you're involved in research, for you to meet like-minded individuals, whether they are your colleagues at other hospitals in the same city as you, or your colleagues who work around the country in similar areas. And so to me, they are the things that drive people to do this. And I think that the real trick is to get people to do it for the first time, because once they've done it once and seen what the benefits are, I think that the rest drives itself. And I should also add that sharing the pain with others of trying to get funding does help. It's not just you against the world.
It's a group approach.
Yeah.
So, Mike, we're just going to change tack a little bit and just talk about some of the clinical experiences. Look, oncology is no doubt a hard field. And I think personally, when I was younger, people would say to me when I said I was going into oncology, "Oh, won't you find that depressing?" And at the time, I very glibly said, "Well, no, I won't." And I think as you get older and have some more sort of slings and arrows of life yourself, maybe it does become a little bit more depressing, and you're getting closer in age or older than the patients that are unwell. How do you deal with that emotional side of being an oncologist for many years and patients that I guess can get under your skin in a way that can make you sad, I guess, for want of a better word?
Yeah, look, again, a really good question. And I think that for me, the starting point is to accept that the standard state of things is that you can't go through your career being happy about everything that happens. Sad things happen. It's sad when people die. It's sad when things don't work out in other people's lives the way they had anticipated. But that is the way the world is to some extent. And to me, it's almost a matter of accepting that and understanding that it's going to be that way whether you're there helping or not. And I would rather be part of this and helping those people, sad though it might be, than trying to shut it off. I also think that the day you stop feeling sad about some of that stuff is the day you probably should stop being an oncologist, because if you can see horrible things and not feel sad, not feel affected, then I think you've lost probably the little bit of humanity that you need to really do your job. So I guess what I'm saying is I don't try and minimize it. I don't try and pretend it's not there. I accept that it's a normal part of life and it just fits in, and it's balanced by the very good things that happen. And for all of us that work, at least in the areas and the particular bits of oncology that I work in, for all the bad things that happen, there are some tremendous things that happen. And that's so satisfying that it's enough, or it's enough for me.
And do you consciously have strategies that if you've had a bad day or feeling down about a situation that you'll go and do something after work, or you just, it's within work, the good things outweigh the bad things?
Oh, well, I certainly rely on my colleagues. I'm very fortunate to work in an institution where I'm surrounded by some really fabulous colleagues, both medical oncologists as well as radiation oncologists, as well as surgeons. And, I think we all have a shared experience of things sometimes being upsetting and being difficult. And I find great support in talking to those other people about what's happened and about how I deal with it. At Chris O'Brien Lifehouse, we have a program called Schwartz Rounds. They've become popular in various institutions across the country and across the United States, which effectively are a mechanism almost of debriefing. I mean, it's not exactly what it is, but that's the purpose it serves. And to talk about how the jobs we do affect us and how we react to some of the things we have to see and do. I find that very helpful, and I see it being very helpful for colleagues. And then finally, of course, I have a fabulous family and friends outside of work where if I really want to be away from work, I can talk with them.
So, Michael, just interested in those Schwartz rounds. Are they a weekly or fortnightly? Who attends those? Is it well attended?
Yeah, so look, the way we've implemented this here at Chris O'Brien Lifehouse, it's basically about every 2 to 3 months. So it's not quite quarterly, it's a little more frequent than that. It's attended by everyone that wants to come. So in a typical Schwartz round, there'd be 70, 80 people in the audience, a mix of medical staff, nursing staff, research staff, administrative staff, effectively anybody that works in the institution who wants to come. And the topics range, but they cover difficult clinical situations, but not really focusing on the clinical discussion, but focusing on how that was managed from a person's perspective. And we would have usually 2 or 3 speakers who discuss that. And we have had all sorts of discussions covering huge range of topics that people just find useful because it reinforces that idea that none of us are doing this job alone, that there's a whole lot of other people around us who are also impacted by what we see and what we do. And each of us have our way of coping, but jointly coping together helps.
It sounds like a great initiative and probably something that a lot of cancer departments would benefit from. Michael, I think you probably already touched on this in some of your answers about leadership, but as I mentioned in the intro, you're now the CEO of Chris O'Brien Lifehouse. What was the motivation to move into that particular role from the Chief Clinical Officer?
So for me, it was really quite a difficult decision because, in the Chief Clinical Officer type role, fundamentally that's dealing with clinical things. A CEO role has some other aspects to it, and certainly a much bigger focus on business, on strategy, on where the organisation should go. For me, it was a bit of a natural progression, and I guess I asked myself, well, do I want to just stick with the clinical bit, or do I really want to be involved in shaping where this institution is going in the future? And I made the decision that that's what I would like to do. And I also felt that it was a good time in my career to do it because I felt that I had achieved about as much clinically as I was ever likely to. So for me, it was just a lucky break, if you like, that the opportunity came at the right time in my career. I referred a little earlier to the fact that I love a challenge. And for me, it was also a challenge, really asking myself, well, can I go in a different direction? And I know that for some of our younger listeners and younger people, that they will have grown up being told how many careers they're likely to have. That wasn't the case for me. I grew up thinking, well, I was going to have one career. And having seen how many people can change what they do and enjoy it, I thought this is something I should try.
And I asked you before about being daunted about roles. Did you lose any sleep at night making the decision about becoming CEO or applying for CEO?
Well, I don't know that I'd lost sleep, but I certainly thought pretty hard about it. And in particular, there are a number of skills or a number of areas of knowledge that as a doctor you really don't have that you need to learn if you want to be a decent CEO. So they were the things I was worried about. But, and I'm sure that you and others will have seen this yourselves, factual knowledge is actually pretty easy to learn. I mean, it takes time, but it's easy to learn. What's much harder to learn is the right attitude, the right approach to things. And I think I was lucky. I think I had those backgrounds, even though I had to learn some very specific technical skill.
And I'd imagine that you probably had to cut down on some clinical work to take on that role. Has that been a bit of a heart wrench to do that, or that felt like a natural progression?
It's been hard. I haven't cut down completely. I still see patients. What I have cut down more or less completely is clinical research. So something has to give, and I don't think you can do justice to any sort of research program by devoting tiny bits of time to it. And so that's really what I've cut back on. And yes, I have reduced my clinical load, but I still love seeing patients. And today, in fact, I've spent most of today in clinic.
Nice. Mike, a bit of a topical question. I know in New South Wales and also Victoria as well, and perhaps other states, that registrar positions are currently undersubscribed, which is a bit of a change in the popularity of oncology, it seems. And in talking to advanced trainees, I hear various reasons about why that's the case, and some of them being availability of jobs and needing to do PhDs for city careers. I'm sure every generation looks back and the next generation seems different to when they were going through. But what do you see as the main issues in regards to people just not wanting to seem to have a career in oncology, and how we can fix that?
I don't really know the answer, and I think it's difficult. It's an interesting observation, people thinking they can't get jobs and thinking there's not a future. You look around the country, there's not a whole lot of unemployed oncologists. So I don't, on the one hand, I understand what they're saying. On the other, I don't really see that's likely to be a problem. I also think if you consider the demographics of the Australian population, we will have a need for more oncologists, many more oncologists. So I actually think the jobs will be there. I do think that there's an element of people thinking that other jobs are easier. When I say easier, I mean, I guess, maybe emotionally, the kind of work. But, again, I think that for me and for effectively everybody I see around me, I see people with enormously fulfilling careers in oncology. So maybe we just need to promote that better. Maybe we need to show what kind of career you can have. I also happen to think that oncology is not a bad career if you want to work part-time, provided you have good colleagues with whom you work. And so I would have thought it has all the hallmarks of something that should be very attractive. I suppose we will need to wait and see whether what's happened in the last, and it's really probably only been the last 1 or 2 years, whether that becomes something that is ongoing or whether it's just a temporary change. Certainly there's been a lot of disruption in people's careers and career plans coming out of the pandemic. There's been people taking time off and doing things in different ways. And so maybe that will settle down, but I really don't know.
Yeah, I mean, it feels like there's more exciting treatment and research areas in oncology more so now than when you were deciding, or I was deciding on a career in oncology. So, I think for people that are thinking about it, there's a very rewarding career ahead of them if they choose to go down that path.
I think that's right. And I think that the even more sort of interesting bit is the things that we think are exciting today are, in fact, more or less in their infancy. And I know it's a little bit silly to say, but, I don't think we have maximised the opportunities with targeted therapies, although that's beginning to get there with much more widespread genomic testing. I don't think we've maximised the opportunities with immunotherapy, and that's very clearly the case. So, I think the next 10, 15 years will be tremendously exciting.
Yeah, I agree. So, Michael, we're almost coming to time, but I guess, again, without making this sound like a job interview, where do you see the next 5 to 10 years for yourself? Obviously, this is a fairly new position being CEO, but what's next for you?
Well, I hope I do my job well enough that for the next 5 years at least I remain CEO, because that's roughly when my contract goes till. That would be bad if that wasn't the next 5 years. After that, I don't know. I mean, I firmly believe that CEOs don't want to hang around too long. You have a period of time where you make your mark on an organisation, but you do then need to clear the way for other people with new and fresh ideas. So I don't really think that I will hang around for 15 or 20 years doing the same thing. I don't know. There are plenty of agencies looking for people. There are plenty of volunteer jobs where people are being sought. So I'm sure I'll find something to contribute to somewhere.
I'm sure you will, Michael. Look, Michael, it's been an absolute thrill to talk to you for this podcast, and thank you for taking time at the end of a busy clinical day. I know this is going to be of great interest to our listeners, and particularly to people that are just embarking on a career in oncology. Thank you very much, Michael.
Thanks, Mel.
Thank you to our listeners, as always, for listening to TOGA's Conversations in Lung Cancer Research. If you like this new series, let us know by rating and reviewing us on Apple Podcasts or Spotify. And if there's anyone that you would like us to interview, please feel free to reach out and let us know.